Thank you. My name is Suzanne Maman, and I'm the UNC Faculty Director for the Rotary Peace Program. I also serve as the Associate Dean for Global Health in the Gilling School of Global Health, where these two wonderful fellows have been based for the last 2 years. So it's really my pleasure to moderate the discussion part of this panel on the role of disease prevention in peace building. And we heard from 2 of our Peace Fellows who will be graduating this spring with a Master's in Public Health and Global Health and in Epidemiology. So we know that conflict can significantly impact health of individuals and communities. Conflict can lead to displacement of large populations, which puts a huge strain on our health infrastructure. Conflict can also lead to the direct destruction of health infrastructure, exacerbating health inequities in these contexts. Conflict can also lead to long-term mental health implications for populations and for communities. So the role of health in the peace-building process is critical. And in 1998, the World Health Organization adopted a Health as Bridge for Peace program, which is a policy framework with the premise that healthcare workers and the delivery of essential health programs can contribute to the sustainability of peace building in conflict-ridden settings. So today we heard examples from our fellows' work to build health programs and to promote prevention in 2 different settings. So Mexon described his work as really leveraging his role as a community member in a context to develop a unique health program that really was tailored to the unique needs of the communities in that setting. And from Simon, we heard about his role in an HIV prevention trial that was designed to address the health needs of women who are at high risk for HIV prevention. So we see through their presentations the foundational skills that they've developed in public health, in the implementation, the evaluation of health programs coming through their work, not just in disease prevention, but in the long-term process of peace building in these settings. So I want to thank them for their work, and I'm going to start with the first question for both of you. In public health, there's a lot of dialogue around decolonizing public health. And so I think it's relevant for this context of peace building as well. And so I'd like to hear from each of you how you think about decolonizing public health and what you think that means for you going forward in your work. And so Simon, I'll start with you.
Thank you, Suzanne. I think maybe we can start by decolonizing the temperature of the auditorium. Thank you. Thank you. So let me situate the problem. 90% of global health organizations are situated in high-income countries. Yet, 90% of global health problems are situated in Sub-Saharan Africa and Southeast Asia. Come to think about it, the very organizations that are supposed to be working to solve the global health problems are not closer to where the problems are. And do you think that it is possible for us actually to implement meaningful solutions that probably are prescribed in Washington and expected to be implemented somewhere in Africa, and that will work? I think that decolonization is the way to go, but the speed at which we are decolonizing is a problem. I have seen different models of decolonization in the course of my work in Africa. I have seen models where, yes, local communities are involved in health programs, but at the end of the day, the financial decisions are still taken in the high-income countries, in Washington, in Geneva. Money is power. If we truly want to decolonize global health, it means that we would have to localize it and then have local stakeholders participate in the solutions and co-create the solutions, because that is what leads to sustainability. If you don't have local communities take charge of their health needs, and then the solutions are rather prescriptive, what happens is that sustainability is going to be a very big problem. So we can solve it from that angle. The second angle is also devolving the power. Let's not concentrate the power where the global health organizations are in terms of human resource hiring. We often see that a project is based somewhere in Central African Republic, and then you don't have locals who are hired to manage the project. The hiring is done again here in the high-income countries, and then you have these professionals now come in, completely removed from the local context. How do you expect that those people will really understand and empathize with local communities in terms of the problems that they are facing? So one way that we can also go about this problem is to ensure that we develop local capacity, like myself and Megzon. If we return to Africa and there are global health organizations here, hire me to be a director. Don't bring a director from Washington. If we are able to do that, I believe that small steps, we are actually decolonizing global health. But I would like to end by giving a practical example of how some institutions are doing things very differently. And that is what excited me the most when I was in Zambia doing this work. And I would like to commend UNC. I know Duke is also doing a great job with respect to that. So what UNC is doing is that it has set up global health hubs across the world. I know at least 2 of them in Africa, one in Zambia, another one in Malawi, and I think somewhere in Kenya, there's probably one there also. And what that is doing is that UNC establishes these global health institutes, and the capacity of the local people are built by or are developed by UNC professors, their collaborations and what have you, their joint partnerships for research, and local professionals are hired to manage the projects right at these global health sites. When I went to Zambia, what I witnessed was that the entire team in Zambia were Zambians and Africans. There was not a single person from the United States or from elsewhere in a high-income country actually involved in managing the projects. But then they developed partnerships for collaboration, because most of the time, for some NHI grants or some of the big grants in the United States, you need to have a partner in the United States. And I think that is a classic example of how we can decolonize global health. Thank you.
Nixon, let's hear your thoughts on decolonizing global health in your context.
Oh, thank you so much, Suzanne. I think Simon already said everything I was going to say. But thank you, Simon. Well, I think that's a very important aspect in terms of 21st century, where the entire Africa, the continent, is growing very fast, is developing very, very fast. I think every time we talk about decolonization, there might be some misunderstanding that Africa doesn't need any help. We just want to do things by our own, and we don't. No, that's not the case here. I think it's very important to understand that there's always a chance to build partnership, development programs. And what Simon was trying to explain is, I believe from my personal experience, that it's very better to look at the aspect of how we can implement any program in Africa that actually have a real impact in the communities that we want to serve. In terms of public health intervention, in terms of reducing diseases burden, like I just talked about in my slide, this is a perfect example of how we need to give more resources to local organizations and coming with so many programs at the international level that always leads to a failure. So I think it's very important to make a distinction, and Africa still need a lot from the Western countries as well as from Europe. and for the United States. But I think it's very important that we think the way we provide assistance to those communities, need to give them more power, and so they can make their own decision on what they believe as a better solution to reduce diseases and also to improve the condition of health in sub-Saharan Africa. So yeah, and also I wanted to agree on the point that Simon mentioned about the human resource, how the human resources in terms of equality on how many staff are actually from Africa in those of international organizations working, for example, in Central African Republic or in Ghana or in Tunisia or in Tanzania or in Zambia. Those are the kind of questions that we really need to ask ourselves. How many people from those countries are in those organizations? Because those are the people that understand better the situation. I have many colleagues who are working in the field, and I'm pretty sure they have more experience than me. They can even do better than me, but they never have an opportunity to speak out or to have a chance to maybe to come to Gillings or to work for any international organization, contribute to the policy making, changing things in the field. So I believe that having that little change will have a huge impact in the African region. So I agree on that, yeah. Thank you.
Great. Thank you. So let's open it up to hear your questions from the audience. I see one hand raised at the top here. If we can get a microphone up, all the way at the top.
Hi. Me and my colleagues come all the way from Methodist University in Fayetteville, and we have a question for Simon. Why are females more vulnerable to HIV, and how does gender inequality play a factor?
Yeah, great question, and I can tackle it from two angles. And your question requires that I open up. So there is the anatomical factors that predisposes women to HIV more than men because of the large surface area of, the private part of a woman, which is rather more lined with epithelial cells, and there is not a strong barrier like it is for men. So that is one of the factors, but also very importantly is the economic factor. In sub-Saharan Africa, inequity and inequality is very widespread, and women are those that, mostly affected. And so because of this economic inequality, women get involved in risky, lifestyles, including prostitution in order to care for their families and in order to care for their children and in order even to care for themselves. And so these are two main predisposing factors that places women at a higher, risk of contracting HIV.
Thank you. Are there any questions from our virtual audience, John?
Yeah. According to UNICEF, the coronavirus in Africa had much less a significant impact than it did in the rest of the world. There were 37,000 deaths in Africa compared to 580,000 in the Americas, 230,000 in Europe, and 205,000 in Asia. This is the lowest case fatality ratio for COVID in the world. Why do you think that was the case, and what could we learn from Africa for how you manage COVID?
That's a well-informed question there. I'm going to ask Mexon to give us his thoughts on that.
Well, that's a very, very important question. Thank you so much for asking that. I think the first reason, based on my understanding of what's has been going on with COVID-19 pandemic is about the capacity building on testing, reporting cases. So I think there are many hypotheses out there that we don't know yet, and we need more data to understand why we have a very low infection rate in sub-Saharan Africa. But I will try to touch base on some of those hypotheses, which again, I think is still hypothesis. So the first one, I think we don't have a capacity for testing, reporting all of the cases. I think there might be more infection rate than what was collected in the data. That's the first one. The second one, it might be the possibility Africa has a community-driven way of managing problems, which I think is much more different than in the United States. Let me give you one perfect example. If there's a case of COVID that is identified in a family, it's pretty easy in Africa that everyone will know that, oh, there's a case of COVID here, so we need to be careful. But I think that's not going to be the same thing in the United States, right? Because it's reporting cases on anyone that you don't know. There is this way of privacy that is very strong in the Western country. So any problem that touches on the public health is considered as a community problem in Africa. And I think that the good point that I wanted to share here, how maybe the United States can learn from that in terms of working together, putting people together to understand if there's a COVID-19, it should be not a political issue, it should be a problem that concerns the country. And also, we talk about masks, we talk about wearing, washing hands, social distancing, those kind of little things. I think even though we don't measure that in terms of data, but my experience, I think those are the things that the United States should learn from Africa on that. And like I say, those are just hypotheses, and we need more research on that. And I'm continuing to ask myself, why is it like that? I don't know. But maybe we'll find more in the next few years. Thank you so much.
Simon, you have anything to add to that?
Yes. So first of all, I was at one point on the front lines, and I actually dispute the statistics, and Megson was right. There was clearly, and there is still clearly, underreporting coming from Africa. Testing capacity in Ghana, at the peak of it, we had only 2 testing sites for a country of 33 million people. How is it possible that we were really going to give the accurate representation or scourge of the pandemic in the country? It wasn't possible, okay? Now, I also think that many people perished from COVID-19 than were reported. I also want to talk about the demographics of Africa. Africa has a very young population as compared to high-income countries or the developed world. And if you look at the data, many elderly people were more vulnerable. So I suspect that the youngness of the African population also contributed to protecting us. And even if there was COVID-19 spreading amongst people, the tendency to develop immunity rapidly in a way that we can achieve even herd community without vaccination was possible. So I believe that these are some of the reasons why we actually recorded low statistics with respect to the COVID-19 pandemic. Thank you.
Good, thank you. So we recognize we're standing in the way of lunch, so we have time for one more very short question. And I see hands raised here. Pilile, yes. Make it short.
Sweet.
Hi, my name's Pilile, and I am a Class 19 fellow. Congratulations to both of you.
Thank you.
So my question was really, I really enjoyed your discussion around decolonizing public health. And what I heard from both of you in maybe slightly different ways was that one key is to really foster true partnership. So even if there are international partners, you know, helping with the technical aspects, with the drug procurement, then there are sort of local actors also involved. And to be short, what I'm trying to get at is, can you maybe talk about, from your experience, if you have observed true partnership? And I want to explain what I mean. Have you heard or seen in the field where there's conversation happening back and forth? So not just, you know, something landing in a country and then something like PrEP being you know, distributed. Are there opportunities for feedback to be shared from the locals, from the end users, upwards to the people that design these drugs? You know, how are we thinking about other populations like adolescent girls who are actually, you know, getting infected at, you know, the highest rate in sub-Saharan Africa specifically? So just, you know, any examples?
Question wasn't short,
Sorry.
but we're going to make the responses short. So in 30 seconds or less, let's challenge you. Either one to start.
Oh, okay.
Simon.
All right. Thank you so much, Pilile. I know you have a lot of experience in this area as well. Yes, so what you have described is the ideal situation. That is where we all aspiring to be at with respect to the decolonization agenda. We are not yet there. There are some global health organizations that the feedback that is giving only ends on the desk of, you know, the managers because it's not so much valued, right? But then there are also those transformative global health organizations that really, really, really take feedback from the grassroots to inform program redesign, to inform program implementation, and even to inform next steps of the program. So that is ideal. Some organizations are there, others are not there yet. And that is why we are all here required to, if we get the opportunity, to advocate and advocate and advocate for global health organizations to be sensitive to feedback that comes from the grassroots and to actually implement that feedback into health programming.
So, Maxon, anything to add in 30 seconds or less?
Yes. And again, I think Simon just answered what I wanted to say. And thank you so much for your very important question. It is very important that all of those organizations working in the public health, education, or any other area, any field, should listen to the communities and to give them the feedback for what they do in terms of intervention. But unfortunately, sometimes we don't observe that. And there are also some other organizations that actually are able to give a feedback in the to the local stakeholder, whether it is the government, the youth organization, the communities, or the hospital where they implement the intervention. So I think there are many things that need to be done, and I cannot say that everything is perfect. Like you said, you know even better than me. Yeah, I think we should continue to advocate for that and to make sure that anyone who is trying to implement anything in Africa, listen to the community, listen to the people living there, especially the key population that we just discussed today. So thank you so much for your question.
Just a very quick one. So you will notice that the refusal to listen to feedback from the grassroots is the reason why many global health projects in Africa and elsewhere have failed big time. And because of those failures, people are now waking up to say, okay, you know what? This has been a very big investment. we didn't get the desired, results that we wanted. And they are now upping their game and strengthening monitoring and evaluation. In fact, many global health organizations today would set aside close to 10 or more than 10% for monitoring and evaluation. And out of the monitoring and evaluation, learnings happen. And then they now pick the feedback, implement the feedback, and we are seeing progress. And it's the way to go. So if people continue to listen, I tell you that we are continuously going to fail. Thank you.